Okay, we're beginning our second panel discussion with a group of really distinguished and very hard to reach people. So I'm so glad that we were able to get this convening together with actually some of the heads, department heads from the various public health agencies to talk about prevention and control around viral hepatitis and how it impacts us in the Midwest. So from left to right, we have Dr. Rashmi Chuk, who is a medical director for the DuPage County Public Health, Dr. Ram Raju, who is the new Cook County Health and Human Services head, Stephanie, and I'm the last name, Borchardt, from Wisconsin Department of Public Health, Dr. Kathy Ritger, who's with the infectious diseases head at the Chicago Department of Public Health, and Aaron DeVries, who is with the Department of Infectious Diseases, Minnesota Department of Public Health. So this is the nice Midwest group that you really want to hear from. And Dr. Karen Kim is actually going to moderate this panel with a couple of questions for them around prevention and control.
Sorry, you guys, I'm not going to stand in the middle of the room. I'm too tired. I'm going to stand behind this podium. So, first of all, again, this is really, I think, what we need to be thinking about in terms of prevention and control of viral hepatitis is how do we have the public health department, which Dr. Ward earlier called the glue, address issues of viral hepatitis and prevention, particularly when we know that there's just so many interesting things on the horizon. And also sort of what Affordable Care Act is going to have is really a big question for most of us. And so I'm going to start off with a question regarding surveillance. Certainly we know that among certain populations, surveillance and reporting is very, very challenging. And without data to drive sort of ideas about incidence and mortality from viral hepatitis, I'm really curious to hear from your public health perspective what should be done to improve, or maybe you already have wonderful surveillance systems around the Midwest, but what are some of the barriers to adequate surveillance, and what would you recommend in terms of how we could improve surveillance systems? And I'm wondering if we could start with Dr. Rashmi Chuk.
Thank you. Yes, well, I think as it's come up a few times today already, I think one effort that would be helpful would be to standardize data collection. And as we were talking briefly during one of the breaks with Dr. Ward, that it may be helpful to maybe focus on the lab requisition data, since often that's the central aspect of reporting. It's the mechanism and the resource for surveillance data, which originates with the provider. So the more we can streamline and elevate the practice of providing key demographic data towards improving surveillance, I think the more robust our surveillance system will become.
Okay, so making sure that we have those maybe within our EMRs, I think will be important. Dr. Raju, I mean, you are representing the major and only safety net system in our state, and certainly in the city, and I'm wondering if you could comment on sort of some of the progress or barriers for surveillance for viral hepatitis for the city.
No, I just want to give a little background in the sense that I'm basically a surgeon by profession, but still I've been in public health for many years. My previous job was I was running the public hospital system for New York City from Mayor Bloomberg. So we will quote a little bit of more of what we have figured out as surveillance. The issue was always a lot of public health department over a period of time did a lot of surveillance, and the surveillance basically collected data, and the data needed to be targeted at the end of the day to what kind of people we need to do that, because we simply cannot afford to do overall sweeping of every population and trying to figure out what it is. It's like doing colonoscopy for everybody over the age of 50. That's great. But eventually we'll outstrip the capacity to get anything done, because the number of people people living longer, the number of people who are going to do that as a part of it. So everything has got to be, the surveillance data need to document who are the high-risk population and who is going to get what and what time period. So somehow we need to take a look at that. At the present time, we look at the public health and the surveillance basically as something the government should do, make sure everything need to be done, especially on a certain disease process like viral hepatitis. The question will be who should be surveyed, who should get it, and what frequency, and how to get them into the care. And most importantly, there must be a direct connection between them and the caregivers. Because the public health identifies an issue. Most of the time, the caregivers identify the issue and let the public health know that. A lot of times, the public health departments basically depends on a passive methodology of getting information. That's basically a medical lab will tell you that this probably got an active infection going on, or this guy is a chronic carrier of infection. But that is a very passive way of getting things done, as opposed to getting an active surveillance should go on. So I think as you do the surveillance, I would really like people to take a broader look at that, right? It is simply we can't surveil, the surveillance cannot be done for every disease process, everybody, all the time, over a period of time. It is something very impossible to get it done, right? So the question will be, who should be done, on whom it should be done, what is the target, what are the issues needed to do that. So those are the barriers, I think, is a mental framework of how we think a public health issue need to be addressed as an individual, as a responsible government, healthcare leaders, how you want to do that. So I would really say that that's an issue, because it is okay with viral hepatitis, but other surveillance methodologies sometimes are kind of branded as profiling of people, that you want to do that. We had the problem with HIV infection. Who should get the HIV testing done? Should it be certain people, or everybody should get it? Then the question came in stigmatization of the test. So if you want to destigmatize the test, then you should offer it to everybody, so that those people who really offer the test would not feel like they're stigmatized. So these are some of the very crucial questions we need to ask ourselves and answer as a public health officials. But I don't think we have really done that good job over a period of time. Right? We just basically, all right, we're going to look at this population, we're going to publish a paper saying 10% of people got this infection, and these are the factors, and this is what we're supposed to do. That model is not sustainable, simply because there are more people are going to be in the country, and more people are living longer over a period of time.
That's interesting. So, whether we have surveillance for all diseases or targeted surveillance, I think that's really an important question, and how do we implement that? Because certainly we know that without data, surveillance data, it's really hard to understand how we have impacted changes in incidence and prevention of diseases. Thank you, Dr. Raju. Dr. Borchardt, I'm wondering if you could make some comments, again, for what has been going on in Wisconsin.
Sure. In Wisconsin, we've taken advantage of a small CDC grant, one of the ELC grants, in order to clean up some of our hepatitis B and hepatitis C data. And we're specifically focusing on more recent data and doing active surveillance to fill in more of the missing fields on these persons. And we're hoping that in its improved form that it'll be better capable of informing future activities.
Okay, that's great. Dr. Ricker?
Hello. Just some background, I guess. Here in Illinois, it's the local health departments that collect the data and are responsible for reporting hepatitis data as well as all disease, reportable disease information to the state level. So myself at the Chicago Department of Public Health and Dr. Chug at DuPage, we're local health departments. And so we are the interface between the providers and the laboratories submitting the data to us, and then we assess it, see if it fits case definition, and make a determination about whether it's an acute case, chronic case. We can't tell whether we're going to investigate it or not. And I think, so chronic hepatitis B and C has been reportable in Illinois since 2002. So we're going into almost our 10th year of having this reportable. I think we would benefit from having, like Dr. Chug said, having some benchmarks for which cases are priorities to investigate. As health departments, we've been making probably most of those decisions on our own. In Chicago, we investigate hepatitis C cases that are under age 20. Anybody who looks like they might be an acute case. But the vast majority of cases that get reported are going to be hep C antibody only, and that's really the only information we get on them, except name, date of birth, sex. And the race ethnicity data is really lacking. So in the last 10 years, we've had about 30,000 unique individuals reported to us as hepatitis C positive, and that may just be antibody. This may not be that they're actually confirmed cases. And about 10,000 hepatitis B cases since 2002. And so many times the race ethnicity data is lacking. So some benchmarks about which cases should be priority. So all health departments were doing the same thing would be helpful. And one more point would be the case definitions are complicated, and sometimes, as Dr. Raju was saying, that when case volume is very high, say for a disease like influenza, we don't attempt to get every doctor to tell us about every case of influenza that's ever going on in the city. It's just too many. So we try to do a syndromic surveillance approach. With hepatitis C, we often don't get the confirmatory test report. It may be that it wasn't done. There may not be resources. The patient may be uninsured. Maybe it just wasn't reported to us. So surveillance data can be helpful even if it doesn't reflect the actual true disease incidence or prevalence. You could have a definition that's good enough for surveillance, and I think even that level of data would be helpful. It may not be adequate for, I wouldn't want to tell a patient that you have hepatitis C just based on antibody result. Never want to do that. But I think for surveillance purposes, we could go with that, and that would be fine.
Interesting. And Dr. DeVries from Minnesota, it sounds like you may have developed sort of a model system that you might want to share with us, and we can put your slides up. But you can go ahead. Yeah, sure. Let's do it.
So I take no personal responsibility for this. Part of this is the way the Minnesota public health law was written a number of decades ago, and that concentrates a lot of the work at the state level as opposed to the local level. You can see here that hepatitis touches many different parts of the Department of Health, from vaccine preventable disease surveillance, refugee health, immunization, clinical services, particularly related to hepatitis B, our Office of Minority and Multicultural Health, sexually transmitted disease surveillance, and a number of others. What the challenge is that it kind of divides and separates a lot of the expertise, but the benefit, the glass half full part of it, is that it allows us to pool resources. We might get a small amount of money from one particular area and be able to bring that and coalesce that together. Importantly, we do have statewide population-based surveillance for both acute and chronic hepatitis B and C. Hepatitis B since 1987, C since 98. And those are our definitions. The majority of this reporting occurs from laboratories. So it is written within our reportable disease rule that hospitals, clinics, healthcare facilities are responsible for ensuring that we are reported for each one of these. And there's specific laboratory tests that result in an automated report to the Minnesota Department of Health. From that report, we do go back and, in a number of instances, gain further information, particularly related to race and ethnicity. This is population rates, so the number of people per 100,000 living with hepatitis C in Minnesota. So this represents chronic hepatitis C. In Minnesota, the American Indian and Alaska Natives are have the highest rates of hep C, followed by Black and African American, which also includes many of our new recent African immigrants. In Minnesota, the Asian Pacific Islander population is actually the fourth most frequent group. And in the next slide, this is in quite great contrast, hepatitis B. Asian Pacific Islanders are the highest frequency population at 3,500 per 100,000. You can see other groups much lower, and if you advance 2 times here, you can see the incredible disparities that we observe. 72 times more cases per population among the Asian Pacific Islanders compared to the reference group of whites, which account for 85% of Minnesotans. So highly concentrated within a small group of people. A very important second data set that we are able to bring together is our refugee health data. And we have had a very strong refugee health community going back a number of years. You can see in yellow the Southeast Asian population represented in yellow has been the dominant community through the 70s, the 80s, and mid-90s, was replaced for a number of years by sub-Saharan African refugees. But recently, in the past decade, we're once again seeing a significant number of Southeast Asian refugees arriving in Minnesota. And the next slide. We collect specific information about country of origin, which I think is also unique. Among our Asian primary refugee arrivals, over half are from the Lao or Hmong communities, followed second by Burma, and actually more recently, a number of individuals in the last few years from Bhutan. And then we'll just show one more slide here. Specifically related to hepatitis B, you can see our overall, among Asian refugees, our overall infection rate is 9%. But as other presenters have suggested, there's significant differences among those populations. So out of 500 Bhutanese, only 1%, 1.5% had hepatitis B infection. Compare that to those from Burma, Lao, Hmong, closer to 10%. So I think what I hope to show you is that population-based surveillance can occur. It takes a lot of resources. It takes a lot of connection. And it takes a lot of effort, but I think it can result in very important, actionable information. And I think most importantly, gives you information about where to target. But secondly, once you've designed those those processes to try to attempt to control hepatitis, it gives you a benchmark, a measure to see your progress.
I think that's wonderful. So, I mean, I think that leads into sort of the next question. So, if you do have an idea of, in your region, what the prevalence or incidence of hepatitis B and C is through surveillance data, and we have kind of a roadmap in terms of the viral hepatitis plan, both described in the Institute of Medicine as well as Department of Health and Human Services, how then does your public health infrastructure use this data to target programs to maybe change these numbers? So I can see in that one slide you have 72% difference between the Caucasian population and the Asian population, at least for B, and then big disparities as well for C. Is there a way that this data then, so since we're asking for surveillance data, how that changes the way you implement sort of a plan for viral hepatitis? And maybe I'll start with you again.
Sure.
And then work our way back.
I think most directly it's impacted the recommendations that we at the state level make back to our refugee health screening clinics. Clearly these are individuals, these are groups that need to be screened at a much higher level, and so that's, I think, the greatest impact. But I think you highlight a very important missing step, and that's our ability to use this to impact greater change, and I think that's a very important thing and something that we need to learn about. And very excited to hear more about your program and how that could potentially be utilized in a greater way in Minnesota.
So, Dr. Ricker, I know that you were mentioning that we do some surveillance, and I know we do a lot, actually, in the city level. And I'm wondering, again, how this data translates into implementation of programs to sort of close some of the gaps.
Well, unfortunately, I don't think we're there yet, to be honest. We're still at the point of being able to try to just classify our cases correctly and do the data analysis and summarization, and it hasn't really, I hate to say this, but I don't think it's really impacted our programs yet. But in some ways, how different might our local situation be than might be elsewhere in large cities? I'm not really certain. So, of course, our viral hepatitis prevention coordinator and others who work in viral hepatitis want to work with Asian Health Coalition and other Asian community-based organizations for Hep B, and for Hep C have been working with the Needle Exchange, been working with CBOs that serve on South Side and West Side with African Americans, and that's sort of where we're at right now.
Dr. Borchardt, do you have maybe comments about implementation of programs to kind of move forward with the viral hepatitis plan?
We've done some targeted surveillance. For hepatitis B, we've targeted gathering very comprehensive information on acute cases and have done perinatal case management. And then for hepatitis C, we focused on persons under 30 years of age, and then also acute cases and gathering more comprehensive information on these folks to try to really focus our efforts.
Okay, thank you. Dr. Raju?
I think we did most of the things. In fact, our experience was with, I was one of the primary investigators of Chinatown in New York when we tried to study the surveillance and figure out how to manage that population, which has got a huge number of Hep C and Hep B as a part of it. One of the things we found out was the education, that the community as such need to come back and say that this is an issue which is among the community, because what we are worried about is the asymptomatic carriers who kind of transmitting this over a period of time, and how do you get them as a part of it. So one we found was education of the community as well as the primary care physicians, because it somehow happened in New York City where the Chinatown really had a lot of Chinese American physicians who basically took care of the patients. And we found them to be an effective conduit to reach up to the patients and able to do that. The second area where we found a lot of things is we went after every contacts, all the contacts through the primary care, and if they don't have a primary physician, we figured out how to get primary physicians attached to that so that they need to be followed up over a period of time. The second population, as my colleague was telling, the perinatal is one area. And the third area where we found a lot of effectiveness is inmate population in the prison system. We figured out as we do this, as a part of it, because we do a lot more on the preventive side of the prison, because there is a lot of contamination or a transmission of those disease processes inside the prison system or outside the prison system when they come out. So again, we found out the effective management of those folks as they are diagnosed inside the incarcerated system, how when they come back, because we ran the public hospital system there. So they all got into the primary care in the public hospital system to follow through and making sure that their contacts are also checked out. So these are some of the well-tested ways of following up patients over a period of time. As I said before, and as was very well articulated by my colleagues, is doing surveillance guides you towards a targeted population. Then you got to do more with that population so that you're able to make that into that. Because a lot of times, as you point out, the data sharing is not there. I don't have to go back and repeat the same data, which we know some geographic areas in the world has got a higher population. When the migrants from that part of the world, then they are more susceptible or more incidence are much higher. So naturally, we need to pick that population as a part of it, as opposed to doing everybody across the board to be able to do that.
I think that's really wonderful comments. I think that it's also how do you translate some of the knowledge that was maybe a successful model for education in New York in terms of primary care providers, and what do we do in the Midwest when there's really a robust population of Asian Americans, and yet the infrastructure for delivering sort of culturally competent or language-specific healthcare services are just so lacking. And I think that's I think a lot of times when we think about Asian health and Hep B and Hep C, we go to the coastal regions because the populations there are much higher. So I'm hoping.
One comment. I think you touched upon a very important point. Our experience in New York City was when the public health officials and doctors went to the Chinese community, it was absolutely, we didn't get anywhere. Most of the education happened from their own primary care Chinese-speaking doctors, able to make a much more deeper impact into the community than somebody walking in and saying, I'm from Public Health Department of New York City. They don't even want to talk to us.
Right.
So that's one important lesson I've learned.
Yeah. Okay, that's really interesting. Dr. Chug, do you have comments about sort of either the programs in place to try to implement sort of the hepatitis B prevention based on knowledge about surveillance data?
Thank you. Yes, I'd like to say that we have a viral hepatitis prevention control plan. I wouldn't say we're there yet. I am very excited about the IOM report and the Trust for America's Health report and the CDC leadership now with new roadmaps and with overall plans for state and local health departments to follow over the next year. I will say that our current activities, at least in DuPage County, are more those activities that are currently funded. So as everyone's mentioned, our perinatal activities are ongoing, and then STD prevention programs, of course, with active vaccination against Hep A and Hep B for those that are at risk. Surveillance-wise, this is data, or these are data that we hope to really.
You want me to put your slides up? Is there something
Sure.
you want to say?
Okay. I was going to cite a couple of them.
IT help. Oh, wait, I see it. Okay. And then I just hit this. Okay. So tell me where you want me to.
So this basically shows our case rates for hepatitis B over the past 5 years, and clearly, Asians have a much higher, significantly higher rate here. Next slide, please. And so this provides some, basically the demographic breakdown of DuPage County. We're located just west of Cook County, about just over 915,000 residents, and our population consists of 10% Asian and 13% Hispanic or Latino, 5% Black or African American. And if we could go to the next slide. So even though Asians represent 10% of our population, they account for 31% of our hepatitis B cases. But if you note in the slide, proportionately, of all hepatitis B cases, we only have race ethnicity data on 55%. I'm sorry, race data on 55% and only 50% in under ethnicity. So our data are as good as what we receive.
Mm-hmm.
But so our current perinatal and STD prevention activities aren't necessarily targeting on our race ethnicity needs basis, but we do hope to incorporate our surveillance data to help guide our prevention and control plans going forward.
That's great. So one of the things that we heard from Mr. Munson was sort of the money that is going to be put aside for community health clinics in order to help close some of the gaps. And I think particularly with health exchanges, many of the minority-serving small physician practices are really going to be kind of squeezed out. And I think that there is going to be a push towards looking at community health clinics to help, sort of close the gap, particularly for underserved populations. So having said that, and with all of you representing, leadership within your respective public health departments, I'm wondering if you could comment on some of the initiatives and of engagement from the public health departments with the community health centers, and how we might, as an audience, also being involved in many public health ventures, how that may translate to improvement of care services for minority populations, and particularly for hepatitis. So I'll start back on the other end, Dr. DeRees.
One mechanism that the state of Minnesota has is, this goes back a few years ago as part of a legislative agreement that ultimately decreased pretty significantly our Medicaid funding. There was created a relatively small amount of money for community-based organizations to apply to as block grant funding. And it's targeting disparities, particularly racial minority disparities. And so that is one mechanism that we have been able to fund some community-based organizations to assist them with a variety of things that could include hepatitis screening.
That's great. Dr. Ricker.
In Chicago, we've been excited about this prospect of the FQHCs, or federally qualified health centers, or community health centers, as being a way to link people to care. Our county system has traditionally been the system of referral for uninsured patients, but of course it's been burdened and unable to take all those patients. So the FQHCs will have, are available on a sliding scale fee basis to patients who are uninsured or underinsured. And over this last few months, Donna Feaster, who's our adult viral hepatitis prevention coordinator, who's unable to be here today, that's the program that CDC funds for all the states and some of the larger cities in the country. She and I have been working together, and we've nabbed a student intern as well, and started doing some investigations into the state of treatment and care that's able to be provided by some of our community health centers in the city, and have learned, and we were aware of some of this before, but really trying to get down the details of what they're able to do, what their capacity is, what type of referrals they might be able to take, what are they looking for in the future, how we might be able to link them to, or support their linkages to academic medical centers, because they may have the capacity to do primary care as one aspect. Some of them are developing the ability to do hepatitis C treatment and develop that specialist care, either through ID doctors on their own, but then as well as having the support of gastroenterologists, hepatologists at the academic medical centers. So we're trying to support that effort and then just learn more about it. And I'm not certain if I thought someone from Erie might be here. So Axis and Erie are the two big ones in the city, and they've really taken the lead on that. And as well as our community, the CDPH has had primary care clinics, and this summer they're going to be transitioned over to community health centers, existing community health centers that will be taking over the care of the patients that were previously cared for by CDPH. And we look forward to trying to work with them to build that capacity.
That's great, great. Dr. Borsha, do you have comments about the integration of services or?
Sure. Similarly, in Wisconsin, we recognize that the community health centers do a very noteworthy job of identifying cases of hepatitis B and C. The challenge lies in offering specialty care to those patients because the services offered at the community health centers in Wisconsin are primary care, and currently we have no specialty services available for these patients, so that would be something that we should seek in the near future.
Raju?
There are a couple of issues. One is that, one advantage in Cook County is both the public system, public health of Cook County, except Chicago, as well as the caregiving part of it, like the clinical medicine, is under one agency. So it's much more easier. That's not the way it was, especially when I was in New York, because I headed the public hospital system, and Tom Frieden headed the public health system. It's a good thing we work together, but sometimes not necessarily we see this. So that's one great thing of integrating the care, because this has got to be, hand in glove with the primary care, community physicians, hospital systems, specialty care needed. So the building blocks are already here in the system to get that done. Having said that, the other issues will be, right, the future of healthcare is basically asking us to collaborate and cooperate with the primary care docs and community-based organizations and community-based providers to provide care. Because if we change the reimbursement model into a population health model, then everybody wants to keep the patients much more healthier. In the viral hepatitis, you would rather keep them healthier as opposed to end up paying for the liver transplant down the line. So the future of healthcare model will probably push you towards working together, because the model so far was not based on collaboration or cooperation. The model we had in healthcare for many, many years are two things. One, it was never healthcare, it is always sick care, right? It's always made it more profitable to make patients sicker than get more money, right? As opposed to preventive healthcare, because they never paid for that. The second part of that is that the healthcare model was basically based on a competition model, because basically everybody was trying to garner other people's market. So if you have a better CAT scan, I'm going to put a much more better CAT scan to attract patients to my system. If you have something to do better, I'm going to really get a better guy to do the same thing. So I think the future of healthcare under the Accountable Care Act, the reimbursement model, population health, all those things will drive us towards the model of working with the community-based organizations. And in Cook County, I'm very happy to see that the public health and the medical care is all linked together in one agency. It's much easier to do that. Second thing, as we are moving towards getting a 1115 waiver for some of our uninsured patients to get into Medicaid at an earlier date under the Accountable Care Act, it will probably help us to work more closely with other federally qualified health centers, other community-based providers, and also community-based organizations, so that we can develop what I call as a regional network of healthcare. So that is something this model will force us to do that. At the present time, it's not regional healthcare because we place hospitals not by strategically, we place hospitals where the market is, right? Where the patients have much better payer mix, and how do you want to sustain your market? So I think I have a lot of hope and optimism for the future of healthcare as we design it, provided the ACA really survives to the Supreme Court and gets into some form of real accountable care. We'll see how it works. So I'm optimistic. I think it'll probably pass, right, with some dents, but eventually I think it'll get through. But I cannot overemphasize any system, any academic centers, any one of them, cannot be able to provide appropriate care without collaborating and cooperating with the community-based health centers. So that is a model we need to work towards as an organization.
That's great to hear. And Dr. Chug, do you have comments about maybe sort of what the work you're doing in DuPage in terms of community health centers?
Yes, our health department is not directly linked with community health centers or federally qualified health centers, but we do have, of our 5 public health centers that comprise the DuPage County Health Department, 3 of our centers are co-located. 2 are with federally qualified health centers, and 1 is with a free health clinic. And we're also fortunate in DuPage, based on need, since we don't have a county hospital system. About 10 years ago, a system called Access DuPage was developed, which is basically a free clinic without walls. It's a network of hospitals and primary care, as well as some specialist providers that are committed, based on whatever capacity they identify individually, to provide care to uninsured and underinsured patients. Now, we do have a pretty robust primary care base as part of Access DuPage, and we do have some specialty, but again, as far as our GI specialty resources, that's a challenge that we're working collaboratively as, the health department's a member of our Health Safety Net Coalition, which is actually led and facilitated by Access DuPage, so they're sort of the central partner that guide it. But all this said, I think, as has been said before, I think that we do feel that we really need to focus on educating, increasing awareness among our providers, as well as our community members, particularly those that are at risk, about the screening recommendations. So that'll be something as part of our action plan that we really try to build upon.
I think that's great. I think that certainly the one message that comes across is the capacity for specialty care is really one big barrier. And so I think when Dr. Rowe was talking about, even a dentist will be able to treat Hep C with these 2 pills a day, I think that we need to work towards getting primary care physicians that are probably more kind of biculturally, that are more bicultural and maybe bilingual, to be able to provide a lot of this specialty care themselves by empowering them, and maybe some of the work that's being done with community health centers and Project Echo type things will provide that kind of capacity. At this point, we're a little early, so if anyone on the floor has a question, this is a really esteemed panel, and if not, then we will move on. But if anyone has a question for our panelists, yes.
I guess I was just really struck by the. Hi, I was struck by the numbers in Minnesota among the Native American Alaskan Natives, and I'm wondering if you could talk a little bit about what's going on, what's being done in that community.
And you're particularly referring to hepatitis
Hep
C?
C, yeah.
Yeah. This has been a long-standing issue, and we spend a fair amount of effort as part of investigations looking at clusters And as part of those investigations, then going out and putting into place various improvement measures. One example, an outbreak investigation uncovered a particular pharmacy that was not participating in the spirit of our needle exchange rule, and that gave us an opportunity to provide education. So that's one example, but it's a major problem that that goes to the rising amount of narcotic use that we certainly are observing in Minnesota, and I hope that the growth of this problem doesn't continue, but it appears that's the trend.
Other questions? Okay, again, thank you to our panelists for joining us today and for your words of wisdom.